Hello and good afternoon. My name is Mark Block. I'm the Director of Thoracic Surgery here at the Memorial Healthcare System and Memorial Cancer Institute. I've had the privilege of providing care to this community for over 20 years, and it's my delight to be here today on the campus of our brand new cancer center as part of our Lung Cancer Awareness Month Awareness Day. So we have a few minutes here where I wanted to introduce you to some of the technologies that we use, but also give you an overarching picture of the way that we approach managing patients with lung cancer. As you may or may not know, lung cancer is the leading cause of cancer death among both men and women, not only in the United States, but worldwide. That's the bad news. The good news is that in the last few years, we've made tremendous progress in improving cure rates, improving the survival of people diagnosed with lung cancer. And a lot of that progress has come not only from developing new and incredible drugs that take advantage of our immune system, targeted molecular therapies, but also in the realm of early diagnosis. And I have some technology here today that I want to showcase to you that we use as part of that process. You may be wondering why a surgeon is talking to you about lung cancer. Aren't we just the ones that do the surgery when someone else decides they need surgery? And the reason for that is that I think for us, as the surgeons involved in lung cancer care at the Memorial Cancer Institute, we feel that we're integral not only to the initial presentation, diagnosis, staging, but the management of patients with lung cancer through the course of their stay with us. One of the things that's happened is that care has become siloed. You see one physician who does the x-ray, another physician who makes the diagnosis, another one who does the surgery, another one who does the chemotherapy. And that approach may be very efficient from a healthcare standpoint, but it's not very efficient from the patient perspective. And so what we strive to do is shorten the time from presentation to treatment. And by engaging all of those activities within one roof, we feel we've been able to make really good progress in helping people get to diagnosis and treatment as soon as possible. So I want to cover some of those topics today. So first, how does lung cancer present? Well, today there are really three ways in which someone with lung cancer will come to our attention. The first is they have symptoms. They have a cough, they have weight loss, they have pain, something that brings them to see their physician. They get x-rays and an evaluation that eventually diagnoses lung cancer as a source of the problem. That's probably the least successful way to make a diagnosis. Once you have symptoms, the cancer has probably progressed to the point where it's going to be difficult to cure. So what we try and do is make the diagnosis early. To that end, we do a lot of lung cancer screening. That's been a very important initiative amongst a lot of organizations across the country, including the American Lung Association, all the hospitals in the region. We all have a lung screening program. We know that effective lung screening reduces the risk of dying by lung cancer by at least 20%, if not more. If you are a smoker or a former smoker, I encourage you to talk to your physician about getting a low-dose CT scan. Very simple test, very low amount of radiation, and it has proven effective in picking up cancers early to the point where we can offer more patients cure. That's probably the biggest reason we've been able to reduce the risk of death from lung cancer. And the third way that people present is what's called the incidental nodule. So somebody shows up in the emergency room because they have abdominal pain or because they fell at home and broke a rib, some other reason, and they get an x-ray or a CT scan that includes a portion of the lung, and oh, by the way, you've got a little nodule in your lung on that scan. That's called an incidental nodule. Sometimes people are aware of it and sometimes they're not, but if that happens to you, I would strongly encourage you to see your doctor to follow up on that nodule, because the proportion of those nodules that turn out to be cancer is actually about 10%. It's very high. And those patients are the ones who probably benefit the most from our innovative imaging technology. When we talk about lung cancer, the first step is to decide whether a nodule is worrisome enough that we should do something about it. What I mean is follow it or do a biopsy. Most lung nodules, and I'll reiterate this, most lung nodules are not cancer. In fact, when we did our big lung screening program, we take people who are smokers who are at high risk, and we do a CT scan. About half of them will have a lung nodule. Only 2% of those are cancer. So the vast majority of lung nodules are not cancer. So the first thing I would do is to encourage you that if you or a loved one has told you you've got a lung nodule, don't panic. It is most likely not cancer. So the first job that we have is to help decide whether that nodule is suspicious enough that we should do something else we should do a biopsy, we should do surgery, we should do a PET scan, some other test to follow up on that. Most nodules are not cancer. We do not want to be doing unnecessary procedures on patients. We want to be targeting the patients who are at most risk and the nodules that are highest risk. So that's really our first task. As thoracic surgeons, we see a lot of patients with lung nodules. That's something we do every day. Nobody's perfect, but we feel that we have an algorithm that helps decide which patients need further intervention and which ones don't. So once we've decided the next step, then we have several options available. In order to make the proper diagnosis and figure out the right way to treat a patient, it's important to understand what's called staging. Staging is pretty much similar across all solid lung cancer. So if you've had any experience with cancer at all, you're probably familiar with the concept. A stage is a scale that goes from 1 through 4. Stage 1 means it's just a tiny little tumor. With lung cancer, it's just in the lung. Stage 4 means it has spread to other parts of the body. Stages 2 and 3 means there's intermediate spread. Because what makes cancers dangerous is not only that they grow where they are, but they spread to another part of the body and cause trouble in that other part of the body. That's called a metastasis. So for example, lung cancer is notorious for going to the bone or going to the brain. In those cases, it's not considered brain cancer or bone cancer. It's lung cancer that is now considered stage 4. And our treatment decisions are based on that stage. And there are basically 3 ways that we treat lung cancers. There's surgery to remove it, radiation therapy, which is very intense X-rays focused on the area to treat the cancer in that one area, and chemotherapy or systemic therapy, molecular therapy, targeted therapy, immunotherapy. Those are medications. They're either taken by mouth or they're go into the vein. And the idea is that they go throughout the body to treat cancer anywhere. Because even when we think a cancer is tiny and just in one spot, there's still a chance it may be in other areas of the body. So we want to be able to treat the cancer everywhere. So for stage 1, where it's really considered early, we tend to favor local therapies like surgery or radiation. For stages 3 and 4, where the cancer is considered multiple areas in the body, we favor treatments that involve systemic therapy like chemotherapy and immunotherapy. And then there are lots of places in the middle where we combine all of our treatments. We do chemotherapy, radiation therapy, and surgery. Chemotherapy first and then surgery, surgery and then chemotherapy. These are all individualized therapies. We now have molecular diagnostics with targeted therapies. So every patient is different. Every patient's treatment is different. That's called individualized therapy. How do we get there? Well, first, of course, we need to make a diagnosis. And there are a couple of different ways to make a diagnosis. When we're dealing with a patient who has a lung cancer or a lung tumor and we're worried about it, one of the tests you might hear that we do is called a PET scan. It stands for positron emission tomography. Basically fancy words that say what we're doing is testing for the metabolic activity. We use a drug. It's basically a sugar molecule that's been tagged with radioactivity. You get a little intravenous infusion that goes throughout the body. It tends to accumulate in parts of the body that are using sugar as a fuel source. So any part of our body that has a lot of metabolic activity, like the heart, which is contracting, is going to accumulate activity, and we'll see it on the PET scan. After you're given the injection, you're asked to lay still because we don't want your muscles, your regular muscles, to accumulate any activity. So when you sit in the PET scanner and it does the scan, it will pick up any area in your body that has increased metabolic activity. Well, cancers, they're growing. The faster they're growing, the more metabolic activity they have. And so a PET scan tends to show cancers. The faster the cancer is growing, the brighter it is. But other things can also show activity on a PET scan. An area of inflammation, especially somebody who has pneumonia or a spot in the lung that's related to infection, that will have activity also. So a PET scan is not really a cancer test. A lot of people think it's a cancer test, but it's not. It helps us focus our attention and further refine our decision about what to do next. The next step is really a biopsy. Sometimes we decide a biopsy is the best way to go. We need to take a little sample of the nodule and look at it under the microscope. And there are a couple of different ways to do that. We have a technology here. I'm going to ask one of our representatives to start playing with it so I can talk about it as we're doing it. When there's a nodule in the lung, getting a sample of it can be done in multiple different ways. The traditional way is to use the CT scanner. You lay on a CT scanner, and the radiology doctor localizes the nodule, gives you a little Novocaine, puts a needle through the skin directly into the nodule. Very safe, very reliable. But there are some areas in which it isn't really practical, and sometimes we want to do more than just sample the nodule. So that's where the technology of navigational bronchoscopy comes in. There have been several platforms over the last 10 or 15 years that have been developed in order to do navigational bronchoscopy. You can think about it like augmented reality. You get a CT scan, the computer takes that whole three-dimensional image of the lung, and then when we do the bronchoscopy, we put a camera inside the windpipe that's connected to the computer, and the computer screen shows us the augmented virtual image of the lung. So the computer helps us navigate the bronchoscope towards the tumor and the nodule, even though we can't see it, but the computer shows it to us on our augmented reality screen. And so Masha here is using this technology. This is a model. This is not a real patient. But here you can see inside the windpipe, and the computer has shown us with this little yellow brick road here, this blue line, exactly which little parts of the airway to follow in order to get to the nodule. And so eventually what will happen is she gets farther and farther out into the lung. We can't actually see the nodule, but the technology will show it to us. So here it is. You can see kind of like it's the augmented reality. So once we get close enough to the nodule, then we have instruments we can put through the bronchoscope that will enable us to take a sample. That's called a biopsy. So this is our navigational bronchoscopy system. It's called an ion system. We've had tremendous success with using it, and we use it quite frequently now to help us make the diagnosis. We can do lots of other things with the technology. Sometimes when patients need radiation therapy, we can leave a little marker behind to help guide the radiation therapy focused on the tumor. And sometimes if we're going to do surgery and it's a very small little nodule, we can leave a little marker behind so that when we get to the operating room, it's easy to find the nodule. So that's the navigational bronchoscopy system. The other thing that we do is we sample lymph nodes. Lymph nodes are little glands, are part of our immune system. We have them all throughout the body. When cancer goes into the lymph nodes, that means a more advanced stage. So often we want to sample the lymph nodes. We have a technology that's very similar to this called endobronchial ultrasound that we can do at the same time as the navigational bronchoscopy. And the idea here is that we have a patient with a lung nodule. We want to be able to come up with a diagnosis and a stage as quickly as possible so they can get to treatment. Often what happens is someone will present with a lung nodule, and then they'll get a PET scan a couple weeks later, and then they'll get a biopsy a couple weeks later, and then they'll get the sampling of the lymph nodes a couple weeks later, and before you know it, it's been 6 weeks, 2 months before we have the diagnosis and the stage. Using this technology combined with the endobronchial ultrasound, we're able to shorten that to, in some cases, less than a week from the presentation to the diagnosis and the stage. So as a surgeon, of course, our involvement is in cutting these out. There have been a lot of developments in the surgical management of lung cancer. We now have many platforms, some related to this, that use what we call robotic technology or minimally invasive technology to help us remove portions of the lung using smaller incisions, faster recovery. We can take out an entire lobe, we can take out the whole lung, or now we're doing what are called sublobar resections for small tumors. We now have very good data that we don't have to take out the entire lobe. We can take out a segment. So you can think of the lung as like a tree. It branches, and each major branch is a lobe, and then each lobe is divided into segments. So we can take out segments and have just as good as a response. But probably the biggest development in the field has been in the area of molecular diagnostics and molecular therapeutics. Doing genetic testing to understand the specifics of the tumor, to understand its risk for recurrence, to figure out if and when it's recurring, and then use targeted therapies or immunotherapy to treat the tumor. Now what we're doing is combining those therapies together, so we're actually operating on patients who previously we would not have done surgery. They get their targeted therapy, they have such a good response that we now believe the cancer is confined to the lung, and there are emerging data that operating on these patients will now improve their chances of remaining cancer-free. So combining all the therapies together now has given us the ability to offer curative treatment to patients who 5 years ago, 10 years ago, would have been unlikely to be cured. So a lot of the progress we've now made in curing people with lung cancer is not only the ability to make the diagnosis early, shorten the time between presentation to treatment, provide better therapies, surgical therapies with faster recovery, but also combining them with systemic therapies that overall give the patient a better chance at survival. So it's been a pleasure talking with you today about our program for lung cancer management. I think the key things are to remember If you are at risk for lung cancer, meaning if you have a history of smoking, whether you quit 10 years ago or 15 years ago, whether you are currently smoking, obviously you should quit smoking, but we recognize that's hard to do. Please come in and get a lung cancer screening test. It might save your life. If you wind up in the emergency room for some other reason and somebody says, oh, by the way, your x-ray picked up a nodule, make sure you follow up on that. There's a pretty good chance that might be a cancer. We don't want you to come back a year later and now, oh, gee, didn't you do anything about that nodule, or didn't they tell you about that nodule? We want to get to it right away. We want to be able to use all the tools at our disposal to help figure things out quickly, get you to the right treatment, and make you not one of those statistics. So I appreciate the time today and being able to talk with you. And our forum is open for some questions. So please feel free to put questions in the comments. And I have some assistants here who are going to ask me and hopefully help clarify some points.
Dr. Block, we actually already have some great questions that have come in. And the first one I have is, from your experience, what are some of the most common concerns patients have before surgery? And how do you help them manage those fears?
So I don't think anyone who is mentally healthy is going to look forward to surgery. It's a scary proposition, right? You are basically giving over complete control of your body to a group of people you don't know very well. You're going to be completely asleep. We're making an incision. We're taking out a part of your body. So it is a nerve-wracking thing to begin with. So it's normal to be scared about surgery. So the first thing I try and do is reassure patients that it is normal to be scared. That is a normal response. And then often it is pretty apparent that patients have had a bad experience with surgery, either personally or they know someone who's had a bad experience with surgery, and that makes them even more nervous about the operation. So I think it's really important to explore that bad experience so we can deal with the issue at hand. And if that's been your experience, make sure you discuss that with your surgeon so you can bring it out in the open and deal with it appropriately. And then, of course, the third issue is, will I make it through surgery? Will it be painful? What's the recovery going to be like? Every patient is different. Most of the time when we do lung cancer surgery, the risk of a serious life-threatening complication is less than 1%. Most of our patients go home in a couple of days. They're back to normal activity within a week or two. But it's a highly individual thing. Everyone is different. Every patient's experience is going to be different. And it's important to have those conversations with your surgeon. What can I expect? Most of the time, if you're an otherwise healthy individual, pretty straightforward operation. It's a pretty rapid recovery and pretty normal, return to a pretty normal quality of life within a fairly short period of time. So often those anxieties, which are perfectly normal, can be discussed and help to lower the anxiety level leading up to surgery.
And that actually leads into the next question, which is, what can patients do before surgery to improve their recovery afterwards?
There are a number of things that are important leading up to surgery. First thing is that if you are smoking, quit smoking. You may feel that the damage is already done, it's too late, quitting smoking isn't going to help, but that's not true. When it comes to surgery, the data are very clear that actively smoking within 2 weeks of surgery increases the risk of a variety of complications, right? The cigarette smoke is toxic to the lungs. It impairs the lungs' ability to heal and clear secretions. So if you are smoking leading up to the operation, it makes it much more difficult for your lungs to recover from the operation. You're at higher risk for pneumonia, higher risk for lung failure, higher risk for requiring oxygen. So if you are smoking, first thing you should do is quit. Second thing is maintain your nutrition. Oftentimes people will change their diet or do something nutty. Maintain your nutrition. Don't try and lose weight. There's actually data that people who are a little bit heavier actually have a better recovery time. So maintain your normal activity. Try and get some sleep. Avoid medications that have blood thinning properties. So not only the prescription blood thinners, aspirin as well, and then there are some herbal medications that will cause blood thinning. So if you're taking anything like that, make sure you discuss it with your surgeon so that you don't take anything that might interfere with blood clotting at the time of surgery.
All right. Thank you so much for that incredible information. And at the same time, we actually had a question that came in related as well to recovery. You mentioned that recovery time can vary. So what are some signs that recovery is going well, and when should someone contact their doctor?
So recovery from surgery is not a smooth, straight line that goes up over time. Your body's been traumatized, been hit by a truck. You were asleep, so you didn't realize it, but your body knows it. And even though you may have little incisions, it was a big operation. So recovering from an operation is a stress on your whole system. It's a stress on your liver, it's a stress on your heart, stress on your lungs, a nutritional stress. So you are going to get better over time, but it's not a straight line. You will have good days and not so good days, especially when you go from the hospital. When you're in the hospital, you're pretty much in the hospital bed, maybe going for a walk. You go home, now all of a sudden you're up and you're moving around a lot more. So it is normal to feel more tired when you get home. It is normal to take naps. The things that are a little bit more concerning are, for example, palpitations. One of the problems people develop after lung surgery is a palpitation called atrial fibrillation. Rapid heartbeat. It's not particularly life-threatening or dangerous, but it does need to be managed. So if you feel those palpitations, take your pulse. If your pulse is rapid or irregular, that's a reason to call your doctor and come in and see them. Things like a cough that is unusually productive. It's normal to have a dry cough after surgery. It's normal to cough up a little bit of mucus. Normally even to cough up a little bit of blood for a day or two after surgery. But if it persists, or especially if it gets worse and you start coughing up yucky looking sputum or something like that, that might mean you've got a brewing infection in there. Fever is uncommon after surgery. Low-grade fever, not a big deal. But if you have a fever to 101, 102, 2 or 3 or 4 days after surgery or a week after surgery, and it's not like you've got the flu and a sore throat, that would be a reason to call your physician. And unusual fatigue, right? Days are going to be, some days are better and some days are worse, but overall you should see a general trend toward getting better. If your appetite is not good, you're not eating well, you're having more trouble getting out of bed every day, those are reasons to suspect that there may be something a little off, and you should probably call your doctor sooner rather than later.
Okay, so now that we're talking about recovery, one of the questions that came in was, what role do family members and caregivers play in a patient's recovery process?
So it's great to have family support during recovery. Most patients honestly don't need it. Once they go from surgery, they're fairly independent. I just recommend that someone be available to help them make sure they have food in their refrigerator and are able to get around. But having a family member there is a bonus, but don't baby them, okay? They should not be couch potatoes. You can help them, remind them they should get up and move around. They can get in the shower, they can bathe, there's no restrictions, especially for little incisions. Now for bigger operations, big incisions, those rules are a little bit different. But for the standard routine lung cancer operation, there are really no restrictions on activity, but it's nice to have a family member there to help remind you to get out of bed, to make sure that you have breakfast, to make sure you have dinner, that you have social engagement to take your mind off of the recovery process. So there isn't any special caregiver responsibility, just be a supporter.
And then, different topic, the word clear margins. Can you tell us what clear margins mean and why they're so important after lung cancer surgery?
So there are two concepts here that I would like to focus on. One is clear margins, which is a pathologic diagnosis, meaning you look at it under the microscope and you can tell that where you've made the cut to remove things, there is no cancer. That's a clear margin. The other one is, did we get it all, which is a question I get from patients all the time. So I will address that. Clear margin is important because, as I mentioned at the beginning, cancers spread and they metastasize. With surgery, the goal is to take out the cancer to clear margins, meaning we want to get beyond the tumor. We do not want to leave any cancer behind. Sometimes the lung cancers can grow beyond the lung. They can go to the surface of the lung and they can attach themselves to the rib cage, in which case we have to take out a portion of the rib cage. We want to make sure that the margins or the edge of that resection is free of cancer. Sometimes the cancer can grow into the center part of the lung. We have to take out part of the windpipe and reconstruct it. We want to make sure that that area where we cut the windpipe is free of tumor. There is no tumor extending to the margin. And that's what a clear margin is called. And that's essential because if we don't get a clear margin, if there is cancer left behind, it is going to grow back. And in those rare cases when it happens, those patients often are recommended for radiation therapy to help control where that was. The decision to do surgery revolves in large part on our ability or our belief that we can get to clear margins. If we see a situation in which we think we cannot get clear margins, then we generally do not recommend surgery. There is no value in taking out almost all of the tumor. We either take all of it out or the surgery really wasn't helpful. There are exceptions to that, but for the most part, taking out most of the tumor, what we call debulking, is not helpful in the curative perspective. That leads me to the other question of, did you get it all? And we get that question all the time. Did you get it all? And there are really two ways to think about it. The first is, did you get clear margins? And hopefully the answer to that is yes. But the problem with cancer is that even when we think it's a stage 1, even when we think it's all in that one area, there is a risk it can come back. With stage 1 lung cancer, we take it out. We know statistically the risk of it coming back is anywhere from 15 to 25%, meaning some patients, the cancer has escaped and gone to another part of the body, and we don't know about it. We may not know about it for 2 or 3 or 4 years. So far, there's no way to detect that. Now we're making progress. But as far as we know, we took it all out. But until you get to that 5-year mark and we can say you're cancer-free, it's never coming back, we really can't say we got it all. So we've gotten clean margins, and it's stage 1, so it's unlikely to come back. But saying we got it all, I don't think is something we can really honestly tell you after surgery.
Okay, Dr. Block, last question. We've only got about 2 minutes left. We asked, the question is, some patients express concern that surgery and letting air get into it will cause the tumor to spread. What do you think about this concern?
This goes back a long time, and it's what I would consider really an urban myth. And I think there is an interesting origin story to it. The short answer is that letting the air get to it and doing surgery on lung cancers does not promote the spread. If it did, we wouldn't be seeing patients cured with surgery. And obviously, if the tumor is in your lung, it's getting exposed to air all the time anyway. It probably comes from the experience 30, 40, 50 years ago when we did not have as good technology for imaging as we do now. You would get an x-ray and see a tumor on the x-ray. We really didn't have a CAT scan. So you would operate, or in abdominal surgery, you would do the surgery thinking the cancer was confined, only to find that it is more extensive than you expected. Close up, go to the family and say, gee, it was bigger than we expected. And then within weeks, all of a sudden it's everywhere. And that's because cancer tends to grow exponentially. When it's small, it looks like it's growing very slowly, but once it has spread and once it gets larger, now all of a sudden it looks like it's growing very quickly. So those were instances in which we did the surgery at a point where the cancer was already spread. It wasn't obvious, but within a very short period of time, it's going to clearly show up in multiple places in the body. So I think it really arises from that experience of doing surgery before we had the technology to know that it was already spread, and really doing the operation at a point in the exponential growth of cancer. So it seemed as though the surgery promoted the growth of it. I think that's really the underlying mythology. Now, there are some cancers that if we cut into it and spill it, it can spread. Lung cancer are not one of them. We know from thousands and thousands of biopsies, we do a needle biopsy on the lung cancer, it does not spread. So although there are some where that is a consideration, lung cancer is not one of them. So we should not be concerned about spreading the cancer by doing a biopsy. Now, that being said, at surgery, we generally don't cut into the tumor. We want to remove it all without cutting into it. But there are no data to suggest that doing surgery, cutting into it, spilling it, will promote the growth of a lung cancer. So I guess that's our time for today. Thank you so much for your time and attention. And feel free to reach out to us, and thank you.
Thank you to everyone for listening to today's Community Connections event. Today's event is supported by Memorial Cancer Institute and the American Lung Association in partnership, and we are glad to bring this education directly to our community. If you have additional questions, please don't hesitate to put them in the chat or reach directly out to the American Lung Association, and we'll bring them over to our partners here at Memorial. Thank you again for listening today, and to everyone who joined us.
We hope we never meet you. We hope you never need our chemo room or groundbreaking research. We hope our specialists never know your name. Though our treatments and technologies are advanced, we hope you never need them. At Memorial Healthcare System, we hope you're never diagnosed with cancer. But if you are, you won't need to hope for exceptional care. It's right here. Memorial Healthcare System. Hope lives here.